is a huge honor today to be interviewing b.korzen, one of the most infamous, famous endodontists I've ever heard of. My friend Ken Sirota, just thinks you're a legend, and you are a legend. I could read your bio all day long, and the reason I'm so excited to talk to you is that in dentistry, it's kind of routine to do cleanings, exams, and fillings, and crowns, and, restorations and all that. But of all my personal friends that are dentists, about half of them say the hardest, most stressful thing they do in dentistry is a molar root canal. And a lot of them, I'll be honest with you, a lot of them feel like they have to do them because they don't have to be a good salesman. The patients come to you saying, God, I got a toothache. So it's not like trying to sell someone bleaching, bonding, or veneers. Right. The insurance pays 80% of it. It's $1,000. For most of my dental friends, it's the difference between losing money that day or breaking your break-even point and going home in the black with some profit. So I wanted to ask you, and of my podcast viewers, the biggest majority are probably young dentists that are seniors in dental school, the first five out of me. Every time somebody sends me an email that I've listened to all your podcasts, they're usually in their 20s. So I want to open up as why don't you give a Vince Lombardi speech about how can you do a molar root canal faster, easier, higher quality, lower cost, and address some of these new pressures that dentists are having, like if the number one cause of a root canal failure is missed anatomy, should I buy a $100,000 CBCT and get a 3D X-ray of every molar before I do it? So that's probably enough starter questions for you. I don't want to start the interview with more than 50 questions at one time. How are you doing this morning?
I'm doing great, thank you, and it's my pleasure to be interviewed by the star. So that's okay. We'll give the accolades back to one another.
Okay.
Okay. It's very interesting. Okay, you talk about should somebody go out and spend $100,000 in order to potentially increase their success rate, etc. And I have to tell you that there were two defining times in my endodontic clinical career where I had sleepless nights after I incorporated something. The first is when I went ahead and bought loops for myself. I said, oh boy, this is really something. And I said, I missed so much prior to that. And then when I brought in the microscope, then I really didn't sleep. I said, how in the world did I have success prior to that moment that I started using the microscope? What did I leave behind? And yet, if you look at the statistics, the success rates aren't that much different between the time we started using magnification and subsequent to that. The difference, though, is I think very much in favor of the practitioner who's doing a lot of endo, because the magnification is variable, so you can change it as you require it. The recording of your cases is excellent, but the lighting that a microscope will actually give you allows you to sit in a much more comfortable position while you're working, and it makes the endodontics much easier. And if it's easier, then it'll go more smoothly. And if it's more smoothly, it tends to go more rapidly. And if it's more rapid and smooth and easier, your success will go up. So it's a combination of a number of things. Should you spend $100,000? I guess it depends on how much endo you do. An endodontist not spending it would be foolish. A general dentist who does one case a month would be foolish. So in between those two extremes, you get the people who are trying to decide and get better loops if you can't afford the microscope. But it depends on the numbers.
Barry, my number one complaint on my feedback on my podcast is that I didn't nail them specifically. So, my whole motto with Dental Town is that with the internet, with Dental Town, no one should ever have to practice solo again. So I know some endodontists just listened to that and said, okay, so then I've heard that these CBCTs, some are better for orthodontics, some are better for just one tooth molar. Can you name a specific name on a CBCT if you are an endodontist and you're just worried about a molar and not worried about the whole head and neck for orthodontics?
I really can't. Okay, I can't because I don't have experience in utilizing it myself because I retired from practice. So I actually cannot name it. But it's interesting you asked that question because just this week, the American Association of Endodontists came out with a position paper along with the American Association of Radiologists, oral maxillofacial radiologists, on the use of those and the president of the AAE also wrote her opinion about both the position paper and her use of it. And she was very much in favor of using it. But she also said that people have to decide, again, it's similar to using the microscope. People have to decide if they have enough use for such a thing. She happens to be in a multi-purpose practice, and therefore they could bring in the CBCT into their practices. On the other hand, she says, if you need a scan, refer it to somebody who has a machine and utilize it for those patients who actually require it. So it's not necessary to jump in and purchase, not like a microscope where you need it in front of you while you're working, but if you need a scan for a specific patient for a specific purpose, nothing to it at all, so refer it. Oral surgeons have them, periodontists have them, whoever's doing a lot of implants have them already. Take advantage of that and get the advantage of the new technology. And it's coming, like everything else. Listen, when I went into dental school, okay, they were just taking out those slow-speed handpieces that had the looped cords with them.
The belts?
The belts, yeah, okay. And they were afraid about the high speeds because the high speeds, if you cut through that tooth so quickly, it's like having power brakes in a car in the old days, okay? I mean, you'd stop too quickly and the guy behind you would hit you. So you have to make sure that everything in time will come to be the norm, just like rotary endodontics is now the norm rather than, I remember 25 plus years ago, I introduced rotary into Canada and it wasn't the norm. It was so revolutionary, please excuse the pun, but it was so revolutionary that when I was lecturing on it, I had former students come up to me and say, but you told us never to use a rotary instrument inside a tooth. And I said, right, but that's when we only had stainless steel. We didn't have nickel titanium. And then I said, we're missing one journal. And maybe Farran publications should actually consider having this journal out. We're missing a journal of retraction. We should be able to publish somewhere say, I changed my mind. Okay? It's not that I don't believe in what I said. It's that the facts have become clearer, and therefore I've changed my mind. That's what happened with rotary, and it's going to happen. It's happening with microscopes, especially within the specialty, and it'll happen right across dentistry with almost anything you can think of a name. So.
Yeah, my first rotary was stainless steel, but it didn't go all the way around. It just wasn't just a quarter turn back and forth.
Yeah, gyromatic.
Yeah, God, I don't think I've heard that word for 25 years.
You want to know something? something?
Yeah,
they're selling them.
Really? Hey, I want to ask. I want you to give a father-son talk to these young graduates because I'm still practicing in Phoenix, Arizona, and I see a lot of upset patients regularly that went to some of these amazing new young dentists in my area. And they are they see the pulp as like a sacred golden cow god that they worship, and they start getting too close to the pulp, so they switch from high speed to a slow speed, a spoon excavator, then they put die-cal, and they do everything to save this pulp, and then they put a crown on it, and then it blows up, and then the dentist drills a hole through it. Then they end up in my office, and they're very upset. And then I think, well, maybe I'm too old and calloused. I've done this. It'll be 28 years. I turn 53 tomorrow. To me, maybe I'm too callous, but to me, I don't worship a pulp. And if I think that thing's close, I take out the pulp because I figure, okay, well, if you're my patient and you're 40 or 50, well, you're probably going to live to be 80 or 90. If it's this close at 50 and then I'm going to file down the tooth and put a crown, that pulp's not going to be there when you're 100. And if I kill it, if I diagnose it to be removed now, you're a happy camper. And if I don't, I try to save it and it blows up on me, I've lost a patient. And that patient might take her husband and two kids and her next door neighbor with her. So where's the balance between worshiping a pulp and saving it with all cost versus, oh, the hell with it, take the damn thing out and do a crown? And I'll further ask that question is, what percent of teeth do dentists crown that within 5 years end up needing a root canal anyway?
So you understand, okay, because the way you lead in the question, you must know this, that no matter what answer I'm going to give, there's going to be a group that's going to be upset with me. Okay?
Yeah, they're going to be upset with you, not me.
For sure. Okay.
We'll play good guy, bad guy. I'm the good guy, and you're the bad guy.
Yeah, sure, because you see, the endodontists say, okay, without a question, and you think this would be the opposite, but the endodontists would say without a question that the best filling material for the root canal is the pulp. And therefore, we have to take all steps in order to preserve the pulp. It's an integrity. On the other hand, once it's been compromised, and the compromise doesn't mean that the caries has to go into the pulp, or the burr has to go into the pulp, or the explorer has to go into the pulp. If it's been compromised because of what's been done to it, either through the caries or through the procedure that's taking place, that compromised pulp, as you said, is going to react. It's a tissue that has been designed in order to wall itself off from what it perceived to be a problem. And that walling off is putting down secondary dentin, putting down a barrier. And if that barrier happens to take place at the cervical line, where now the canal itself is narrower to start with, and it starts to block off the canal so that subsequent treatment may become necessary, it's doing everyone a favor by actually sacrificing the vital pulp at that stage, because vital pulps that are removed have a much higher success rate than when you're dealing with infection and necrosis, and especially if that infection happens to go into the periapical region. So you're doing everyone a favor. You're making sure that the patients will be comfortable, because you should have virtually no discomfort subsequent to the treatment of a vital pulp and doing the endo. You can do it in one step, one sitting. Patient will be comfortable. You can then proceed and make the ideal crown preparation, because you don't have to worry about staying away from that pulp that you've already removed. Okay? It's there. It's in your garbage. So that's far away already. So you can just do whatever is the best preparation necessary, put on the best crown, and as you said, it'll be there, and it won't cause you concerns later on as the patient ages. And you'll have a happy patient, you'll be happy, and that's how you build your practice. By looking at the pulp as something that is reactive, that is not there and it's just a stump that's going to bleed, okay? And I've seen people trying to just control that bleeding. I tell you, the best way to control the bleeding, take the pulp out, okay? You control it by removing it, and then you finish your endo, and it'll be an easy endo to do because you're dealing with a canal that's easy to instrument. Instrument it fully, quickly, dry it, fill it, done.
And we're really managing two things. We're managing a tooth, the dental health, but we're also managing a patient's mind, the mental health.
Oh, for sure, 100%. And it's very interesting when you said that. It reminds me, the first thing that I ever read when I was in dental school about endodontics was the textbook by the late Louis Grossman. Okay.
Oh, Grossman Cement.
Yeah. Okay. But Louis Grossman wrote the first, Bible on endodontics, and it was very, very interesting because when you open the book up, on the very first page, he only had one sentence. Okay. He said, "Treat the patient as a whole, not the mouth as a whole." Okay.
Oh, wow. Say that again. Treat the patient
as a whole, not the mouth as a whole. Okay. And I think by doing what you suggested, we are treating the patient, not specifically the tooth. Okay. And I think that's a very, very important thing to consider.
Oh, are you a romantic, dental romantist? You know what I want to do is we're starting an audiobook section on Dental Town because the market's going to, like these podcasts.
Right.
85% of these podcasts, they're listening to them while they're driving to work. They're multitasking. And audiobooks have now taken over print books. So I'm going to start an audiobook section on Dental Town. It's going to be up in a couple months. But I want to get guys like you and me to go back and read some of these classes where we just sit down and read into a microphone for 6 hours so they can read like this Louis Grossman textbook. You know, that it's gone. It's really gone. The 5,000 kids that just got out of school, they're never going to see this book. But if guys like us bring back these old classics and put them in audio version, we'll bring Louis Grossman back to life.
That's right, absolutely.
So I bought the first 3 books by G.V. Black, and I mean they're novels, and I'm going to literally sit down and read every single one. I would read Pierre Fauchard's book, but it's in French, and I'm going to have to find someone. Do you speak French? You're from Canada.
No,
so
I'm from
you're,
Canada, but I'm not from that part of Canada.
You're so French Montreal, but you're from Toronto, Canada.
Right.
And then you went to Harvard.
Went to Harvard for endo, correct.
And where are you now? Are you in Toronto?
No, right now I'm speaking to you from Israel.
Tel Aviv? Jerusalem?
No, Jerusalem.
Wow. How many miles is that from, what is that, 10,000 miles from Phoenix?
Oh, it's got to be more. It's 10 hours difference in time.
Wow, that is so amazing. I think you're my first guest from Israel.
Here we go. Okay.
That is all. So I want to ask you another thing about the infection. When I got out of school, it was overly simplistic. Streptococcus mutans cause decay. Now we're hearing microbiologists say that almost every quarter they discover a new bacteria in the cavity. And what's more interesting is by the time the cavity gets 4 millimeters deep, they don't even find Streptococcus mutans anymore. When I was in school, P. gingivalis caused gum disease. Now there's, more than that. Is there a main bug that's causing endodontics, or is it just all over the board? I mean, when you say there's an infected pulp, because the question is going to be, these young dentists are always thinking, I need to put you on antibiotics for today, and we're going to do the root canal tomorrow. Is there a main bug? Is there a main antibiotic? What do you do in triage?
Okay, I think one of the biggest problems we have in treating patients who come in with an emergency situation is that they are they never get scheduled in. Like, in other words, you say, how many emergencies am I going to have today? Because I like to sort of put that in. So they never get scheduled in. And unfortunately, we've all fallen into the big problem of trying to deal with the emergencies in an expedient way, and that often means that we do something incorrectly, like over-medicating. I mean, it's been a big thing now about these superbugs developing in hospitals, et cetera, because of over-medication. And in endodontics, I think the practitioner sometimes forgets because they're pushed against the wall. The patients always expect us to do everything right away. You go to a lawyer and ask them a question, they'll say, we'll get back to you with our thoughts on that. You go to a physician and say, we'll run our tests and we'll get back to you with the diagnosis. Go to a dentist, they want it done today, okay? Not this afternoon, okay, and not later this morning, but now. I want everything done now. And so what sometimes happens is that we get sort of backed into this corner where we think we have to do everything right away. And sometimes what happens is that the dentist might prescribe an antibiotic because the patient has pain and you really don't think you have enough time to deal with them the way you would like to, so put them on the antibiotic for 24 hours and bring them back when you can bring them back in a more convenient time schedule. The only time antibiotics really should be prescribed is when there are signs of infection, which means swelling, redness, okay, pus that gets developed if you're doing an incision and drainage. That's when you have to do the antibiotic regimen. Other than that, what you have to do is you have to remove the source of the problem. It's faster for you. Now, there is nothing wrong with a patient coming in a lot of pain, with you going ahead and giving them some local, after you've done a diagnosis, of course, the proper diagnosis, giving them some local anesthetic and saying, we're going to help you out today, and we know you've been in a lot of pain. This will get you comfortable now, and I'd like you to sit in the waiting room for the next half hour, 45 minutes, whatever, until I finish my scheduled patient. I'll bring you in and make sure you're comfortable. And then the best thing you can do for that patient is to go ahead and initiate the endodontic treatment. Not do a pulpotomy, but do a full pulpectomy. If you can't do more medicated, close it up at that time. But at least get the pulp out completely, because that's where the source of the discomfort is coming from. If there's infection, if when you open up the tooth and the pus is draining out, you've got to get them on an antibiotic. But that's after you've looked at it and made your diagnosis. At the same time, once you've done that for the patient, you have to make sure you're doing something for yourself. And that is, you have to make sure that you're not adding any bacterial contaminants. Again, too many young practitioners, even though 100% of the cases they did in school were done with a rubber dam, when they come out, they think that's a step that's part of academia. It's not part of routine. And that's not correct. The tooth has to be isolated. There's no question about it. The bacteria that are common for the inside of the mouth, for the saliva, are not common for the root canal. And if you go in there and start putting instruments inside the canal and pumping these bacteria with the salivary contamination, you're going to have a problem. And that problem is not going to happen tomorrow. It's going to happen tonight when you're home with your family and it blows up on you and you have to make that return trip to the office. But if you take those few extra minutes, put on a rubber dam, isolate the tooth, clean out the pulp, medicate it, tell the patient that they'll have some discomfort because they came in with a lot, and if they expect some, they'll be able to deal with it. If they expect to go home from the dentist and have no discomfort because they paid for treatment, and you haven't warned them about the normal post-operative feelings that they're going to have, they're going to call you. And if you want to retain the patient, you have to respond to that call. So do all the things that are necessary to start them on the road to healing. Don't skip steps, and don't push them off. That's the best message I can give.
I thought they meant when they said practice on a rubber dam to put a rubber dam on the ceiling above you so that you're always practicing under the rubber dam. Is that?
I'll tell you something. Listen. I'll tell you something. This is a true story. Okay. I got called into the dental clinic once at school when I was head of Endo at the University of Toronto. I got called into the clinic with a student, a fourth-year student, who had the instructor sort of hovering to the side, and they wanted me to demonstrate something. And what was it? They had done an incision in drainage, and they were going to put a rubber dam drain in. And there they are with this big 6x6 piece of rubber cut into the shape of a T, trying to force the 6x6 into this tiny little slot that had been created. And I said, "What are you trying to do?" So the student says to me, "Well, I told the instructor that you gave a lecture on this and you showed us how to cut that, and I'm trying to put it in." And he said, "If Korzen showed you how to do that, I want to see him do it." And all I was doing is standing in front of 125 students, and so they all could see, I took a 6x6 and cut it into a shape of a T. And this person, and probably half the class, thought that I meant you take a 6x6 and shove the whole thing into this little slot. So, you know what? That's practicing in the rubber dam, not under the rubber dam. So,
But back to what the antibiotic, if you had that draining that red, you don't have a culture, you wouldn't know what bug it is. So what would be your Stevie Wonder shotgun antibiotic, or do you think statistically you know what bug it is?
You know what? I think you have to go statistically as far as what works most of the time. Okay, and I think what works most of the time is the amoxicillin for the great majority of patients who are not allergic to penicillin. But you'll find that you'll use fewer and fewer antibiotics if you just take the pulp out. You really will. Because if you've got drainage, if it pours out and then all of a sudden it stops, you basically cured the problem. If you've done an incision in drainage, there's little likelihood that you're really going to require the antibiotic because you're given a egress for escape for the infection. So, I'd stay, as much as possible, I would stay away from the antibiotic route.
And you mentioned those three papers. Is there any way on Dental Town we have 202,000 members from 206 countries who have posted 4 million times, and we have it 51 categories, and one is endo. Is there any way you could post those three papers on the endodontic forum?
The paper on the
CBCTs that you were talking about earlier. You said there was a position paper from
the position paper, right?
And then there was another paper written by the president, the woman who this summer.
Yeah, I will write her and ask her for her permission to repost it. I'm sure they want it reposted because they like it. It's no problem.
And you could post that on Dental Town.
Yeah, sure thing.
That'd be that would be so amazing because I know a lot of our viewers just heard that and they want to read that. So I want to ask you, when a patient looks us in the eyes and says, Dr. Korzen, what percent chance? I mean, what's the likelihood that we hear this all the time? My cousin Eddie had a root canal, and guess what? They end up pulling it anyway. And so then when you ask it, when dentists are sitting at lunch together and you say, well, what's a percent rate, the success rate of a root canal? I mean, dentists quote a wide range of numbers. I don't know anybody who's more expert on this than you. What do you tell your patients? And we're talking about a molar root canal, not number 8, not an incisor. But for a molar root canal, someone says, well, what's the percent chance that this thing's going to work? What would you say to the patient?
So let me just go back one step, and that step is that the expert on this is actually Shimon Friedman, who is the head of endo at the University of Toronto after I left. And he was the head for over 20 years, and he's just retired from that. And he actually published a number of papers called the Toronto Study, where they studied thousands and thousands of cases that assessed the success rate, and from everything to endo vital cases to retreatment cases, etc. So he is the expert. I'm not the expert. I just talk about what other people have found. And basically, what they found was that the success rate is exceptionally high with endo. You really can't take a number and apply it to a specific case because there are factors that come into the case, such as the healing capability of the patient that you're treating, okay, just as one sort of thing. But I can assure you that the success rate is exceptionally high, close to 90%, and that in that 10% that do not fall within the success, the initial success, if those cases are retreated, then you're talking about another 60% of those retreatments that are actually successful. So we're bumping up that initial tooth that could be anywhere to around 95, 96% of the way we started. Now we're starting with cases, a lot of the time, there has been a compromise of the pulp. Whether it's just very inflamed or whether it's infected, it's been compromised. An oral surgeon would never put an implant into a compromised bone in the tooth. They'll always start with something that has a great chance of working because it's not infected. You're not going to stick an implant into an infected site. So when we're comparing the alternatives between doing something with the tooth, which is endo versus implant, I don't know very many dentists, actually I don't know any dentists, who would actually in their own mouth elect to have the implant before they try the endo. Because you could always go to the implant if the endo failed. But the third thing is extraction and no replacement. And of course, there will be people who will accept that as well. Neither yourself, your dental townies, or myself will be able to convince those people, no matter what we say to them, or no matter what statistic we give them. But endodontic treatment has always been, and will continue to be, the forefront of saving teeth. This is the way we save teeth. We can replace teeth more sophisticatedly than we used to be able to because of implants versus dentures. But to save teeth, endo is improving all the time. Our technology is improving all the time. Changes almost on a day-to-day basis. And it's a great thing for the patients to have choices. And me, if I needed something, I would have the endo first. I'm sure you would. And then we look at the alternatives if it's not successful, but that's very infrequently.
Very, help these young kids out. The most common endo question I see for dentists on Dental Town that have only been out 5 years. There was one just posted again late last night, so he's stressing about it this first thing in the morning. They have a hard time looking at the broken down molar saying, should I do a root canal or should I pull this and do an implant? And the question last night, he was saying, I don't know if I can get a 2 millimeter ferrule all the way around the tooth. Or would you just talk a little bit about helping a young kid deciding what goes through your mind of saying, you know what, let's try to save this, or you know what, this has been violated. Let's go next step, extraction implant.
I think the most important thing is for the individual to recognize what their limitations are. And if they put into place those limitations and know where the barrier is, then the next question that they have to ask themselves is, now that I know my limitation, do I impose my inability to go beyond that onto this patient, or is there someone else who can take care of this for the patient? Now, if we go ahead and we say to the individual dentist, saying, you have two choices. You can do the treatment because, it falls within your parameters of what you're able to successfully handle. Great, then no problem. If, on the other hand, it falls outside of those, then they have to decide, is referral to someone else a viable alternative? In many places of the country, it's not, Everything is dependent on the individual practitioner because there is no viable alternative. There may not be a prosthodontist to send them to. There may not be an endodontist to send them to. There may not be a periodontist to create that. Everything falls on that solo practitioner, and therefore those parameters are the yes or no, very easy to make. I think the last thing you have to consider for any practitioner is the monetary aspect of it. Because even though it's very important for practitioners to be able to say, if I refer this patient out, I could have paid my expenses for the week on this one patient. I think now that doesn't become a dental question, that becomes a philosophical question. And the one thing that I am very proud of about our profession, that's kept me interested in the profession for so long, that makes me love the profession, is this camaraderie that we have with one another, that we rely on one another. You've created it with Dental Town, where everybody now can feed in to one another. It happens in the small community as well, that you can say, look, I've got this patient, and I'd really love to treat them. Maybe you can just see them for a consultation and help me along with this and get me to the next stage. When I know that I can't treat it, the next one is yours. But just help me go through this. And I don't know any dentist who would not help another dentist out when they're asked for their opinion and their expert advice. So.
I know, and the most beautiful thing you said on this interview so far was that you ask any endodontist and he'll tell you the best thing to be in a save a tooth is the pulp tissue. Or how did you word that exactly? The best filling
for the canal.
And so many of us dentists, my number one hobby is water fluoridation. And I've spent so many gazillion hours answering every city councilman and all this. And here's a profession that tries to reduce its business with water fluoridation and has been successful in 70% of the American towns. And then how beautiful is that?
I got to tell you something. Can you imagine the Association of Undertakers of America actually raising funds for cancer?
Yeah.
Oh.
Yeah.
It's not.
Okay.
It's not
I want to ask you another question. I think some of these I think a part of the human mental condition is sometimes we oversimplify things, and I think some of the dentists might have thought, back in the day, endo was 2 appointments. First appointment, you'd find all canals, clean it out, medicate, get them back 2 weeks off trade, and then we move to one step. But I think some people are one-stepping way too much. Will you talk about when one step is appropriate and when it's definitely not appropriate?
Sure. I think that, number one, that if the pulp is vital and you're doing elective endo, there's no problem whatsoever in doing a one-step. If it's a situation where the coronal portion of the canal has started to break down, but the apical third half of the canal still has vital tissue in it, you can do one appointment endodontics, because the connection to the periapical region is still in a normal state.
But how does this kid know that the apical third is? How does he know he's dealing with vital tissue? How does she know that she's pulling out vital tissue and not infected tissue?
If you go in with an instrument that allows the tissue to actually be removed in toto, okay, like a small barbed brooch or a rotary instrument turning very slowly, perhaps even a rotary instrument that you use with your thumb and forefinger to rotate it. If you're able to get this tissue out, okay, in a solid piece, you're dealing with vital tissue. If, on the other hand, by going into that apical third of the canal, you initiate a lot of hemorrhaging, it's already inflamed. And when it's inflamed, the periapical tissue is inflamed. And when that's inflamed, all you're going to do by instrumenting completely is you're going to force some debris down through the apex. It happens all the time. You'd never get 100% of it out through the coronal. And anything you push through the apex that's already inflamed will create more inflammation. That's why cases that have large apical radiolucencies actually end up being more comfortable post-treatment than those that were vital cases, because you have no vital tissue in direct contact with the apical constriction. So you've got a lot of leeway. If you get a puff of cement out there just going into the space, it's not pushing up against the vital tissue. So if you're dealing with something that was either infected or inflamed, do it in 2 steps. There's no question. But I think one of the most important things is allowing yourself enough time to do it in one appointment if that's your initial intention. The worst that can happen is that when you go into the tooth, you find that it's a case that shouldn't be done in one appointment. And if that's the case, have another cup of coffee, because you've now built yourself some spare time. But if you don't leave yourself enough time and you decide partway through the treatment, maybe I can finish this, that last step is going to be less than ideally done. And unfortunately, even though it's the most important part of endodontics is what you take out of the canal rather than what you put into the canal, if you haven't taken the proper time to instrument, then what happens is that you'll never get a proper seal of the canal. There was a paper that was written in the 1870s, published in the Journal of the Canadian Dental Association, where somebody described filling the canal with sparrow droppings. Okay? Right. And he had a very high success rate by his standards. Okay. So again, it's taking things out of the canal that shouldn't be there once you've encroached upon that canal space. That's going to make or break the success. You know, if you just fill the coronal half of the canal, a lot of the time that might be sufficient, but we don't know in that patient's lifetime how much gingival shrinkage there's going to be, how much bone exposure there's going to be, how many accessory canals are going to be exposed as everything shrinks away with time, and therefore you don't take any chances. You fill the entire canal to the best of your ability. So you have to leave yourself enough time to do all that. If you've scheduled enough time, great. If you haven't, stop. Make it into appointments. Okay?
But more specifically, Dr. Korzen, are you saying that you don't do a one appointment, you do a 2-step because of post-operative discomfort or because of 5-year success rate?
No, I say you don't do a single appointment because of what you find in the canal. I think much too often that a lot of us have gotten used to cookie cutter types of treatment. Say, if it follows within this range, and we have a chart, and if we push that button and we say, oh, there we are, We can do this one in one appointment. It's the patient, okay, that's going to create the criteria for you. If you have someone who has all of the criteria of being able to be done in one appointment, and yet they walk into your office and they're exceptionally nervous, and they are concerned about every little thing, like the light bulb is flickering in your overhead, are you going to be able to see enough? Okay, that sort of thing. That's not the patient that you want to take any chances of actually inadvertently over-instrumenting or getting some sealer through the apex and that creating a problem which will lead them into having some discomfort. What you want to do is make sure that you've taken all of the steps to treat that patient in the best possible way that they are comfortable after they leave your office and will stay that way. And that's your best advertising. And somebody said, you know what? I had this root canal done. I had it done in 2 appointments, but I got to tell you, I don't know what people are talking about. Okay. Listen, I remember seeing an ad, a full-page ad for HP computers about 20 years ago when computers were like the new thing on the block, okay? HP computers with somebody sitting on a chair going like, selecting your next computer shouldn't be as difficult as deciding on having a root canal, okay? So it's, we've come a long way since there, but every patient has to be looked upon as their own entity. And you can't apply the rules just the same way you shouldn't when you're instrumenting a canal, for example, okay? You may 90% of the time do step 1, step 2, step 3, step 4. But for that patient, what you find inside that root canal may mean that you go step 1, step 3. You don't need step 2 for that patient, okay? Don't go to step 2 and spend the time because it has to be done because that's the rules. On the other hand, you don't skip a step just because next patient is in the waiting room, okay? You have to make sure that everything is done based on what you find for the patient for the best interest.
Barry, we hear some people saying that, I want to ask you if true or false, that the number one cause of root canal failure is misanatomy, which is why some actuary people will say the number one failed root canal in America is the maxillary first molar because they missed MB2. The second most failed root canal is a mandibular second molar because the distal canal is 2 canals, sometimes 1. Do you think failure rates of root canals follow missed dental anatomy like that, or do you think that's an oversimplistic statement? And what if someone said to you, what if one of your students just said to you, Barry, list the top 3 or 5 reasons why a root canal fails? How would you answer that?
I think that the missed anatomy is a very significant situation, especially when you're dealing with a necrotic pulp, because then what you have is necrotic tissue that's been left behind. On the other hand, if you're dealing with a vital pulp, these other canal aberrations may or may not be of significance. I think that some of these missed canals, and the one that I found most difficult while in treatment were lower anteriors, because they're very difficult to pick up radiographically, very difficult to get into and to complete. The saving grace of these was that very often they started at the same point and they ended at the same point. They came around and looped and came back to the main canal. So we actually sealed both ends of those missed canals, and that's why we had success. But if there's an egress for those canals to a point where you're not able to seal it, then we have problems. And that's why irrigation is such a big factor now in endodontics. By irrigating the canals profusely, and the materials that were used for irrigation, we've used them for years and years and years, but now we have more great methodology in being able to utilize them. They are able to get into parts of canals that we cannot instrument. We may even be able to see them, but these are accessory canals that may come off on an angle. And in order to access them, we'd have to destroy so much tooth structure that we may be weakening the tooth that we're trying to save. So it's a toss-up situation. I think root canals are successful most of the time, and the failures are due to, as you said, missed anatomy, sometimes misdiagnosis, okay? Sometimes iatrogenic problems. Okay, sometimes a problem that's created by the dentist rather than helped by the dentist. We're dealing in a very tight area where sometimes success is measured in the millimeters. Okay, like there was a big discussion on Dental Town last evening, about what do you do about can a number 20 file clean out all of the vital tissue, okay, at the apex? I don't know. It depends how big the canal is. Okay, that's basically the answer. But people are concerned about the small things, and rightly so, because that's what makes us good professionals. That's what drives us to improve, by looking at that last millimeter. Can I do better in that last millimeter? And are we going to get failures? Sure. But if physicians didn't get failures, we'd have no cemeteries. Okay, it's the way it is.
I'm going to ask you an embarrassing question, but I can't think of anyone better to ask for it. But you know how they say some topics. You know how they say some subjects are just in the closet. I never see this discussed on Dental Town. But when you're going out to dinner with dentists, I mean, every once in a while, after a couple of drinks, some dentists will say, you know what? If I just think something's wrong with this tooth, or I think there's bugs, or I'm just not sure, I still go back to Dr. Angelo Sargenti's formula, because I think, why not put some stuff down there that's going to kill all the bugs and germs, and then I still use my gutta perch and everything, but I'll switch from like a Grossman cement to a Sargenti deal, because I want an active ingredient to kill those bugs, because I'm not sure about this one. They never say it in public. They never say it. But if you watch the dental lawsuits, obviously there's dentists in America using Sargenti root canal. So my question is, did you ever meet Angelo Sargenti from Italy? And what would you say to dentists that are in privately every once in a while using that?
Well, I have to tell you, I'll relate a story to you. I never met him personally, but I actually was in a lecture that he gave in Toronto, and it was interesting that he gave different lectures on the same topic depending on the audience he was speaking to. When he was asked why, and of course, his Sargenti material he called N2, because N2 was the second nerve. Okay, and
I never knew that. What does that mean? The second nerve?
Second nerve. Well, he took out one nerve and he put something else in, so that's the second nerve.
I never knew that.
That's why he called it N2. Okay. Now, when he was asked if he why he developed this, okay, in the way he did, he said his original reasoning was for those poor people in developing nations, and at the time, Europe in general was more of a developing nation as compared to the U.S. I think they've surpassed in certain areas of dental research, etc., all of North America. But his rationale at the time was to help people out who couldn't afford to keep their teeth, to make a paste that, in case the instrumentation didn't completely remove all the debris, this paste would kill whatever was left. You see, a lot of the people would keep their teeth and they'd be better off. It was way before implants, etc. So he says it's sort of been taken out of context now. So when he spoke in Toronto, he spoke about using it as a sealer along with gutta percha in order to help take care of any remnants of bacterial debris. When he went to Northern Ontario, where dentists were few and far between, he used to tell them fill the whole canal with it, because he had the assumption that they didn't have the technical ability to take care of the same things as the big city guys were able to do, and he didn't want them to run into problems. So somebody in the audience said, Dr. Sargenti, have you ever had a root canal? And he said, yes. And he said, was it done with your N2? And he said, no. He said, well, how was it done? He said, I actually went to Herb Schilder to have it done. He said, why? And he said, because I could afford it. And I think that summarized the whole thing. Now, I have seen cases where the Sargenti paste has been pushed through the apex, always inadvertently, okay, but has caused so much necrosis, has caused nerve damage when it's gone into the mental foramen. And the problem is that with every other sealer that we use, people are happy to see a puff of the sealer at the apex or a puff of sealer at the exit of a lateral canal. If it's an N2 or a Sargenti paste, you don't want to be happy, okay? Because that patient is going to be in pain. It's problematic. It has to be removed right away surgically. It's just not worth it. You don't need that sort of material to be put into a canal. It's like taking a cannon and filling it up, okay, and then just shooting it out, hoping it won't hit someone. But we're dealing with an empty space that typically has an opening at the end of it, and if we apply our filling materials under pressure, some of that's going to get out there, and it's going to cause a problem.
And I just recently saw a lawsuit where it went out the apex. It completely pickled the inferior alveolar nerve, and the patient got the full maximum of the malpractice of $1 million.
Yeah, it's just not worth it.
$1 million. And I was saying to myself, I wonder if I would just go purposely get paresthesia for $1 million.
I can't just have a root canal.
So I want you to talk about your amazing. Tell people what Zendo Online is. How did that come about? Tell everyone about Zendo Online, and where did that name come from? Was that from the book Zen and the Art of Motorcycle Maintenance?
No.
Did you ever read that book?
No, I didn't.
That was a big hippie. I went to Creighton University in Omaha, and I wasn't there a day, and a priest walked up to me and said, you got to read this book. It's Zen and the Art of Motorcycle Maintenance. It'll change your whole philosophy on life. And it was a great Zen book. And when I first saw Zendo Online, the first thing I thought of is Zen.
That's actually that's where we got the name from, because we're trying to bring the Zen approach to endodontics. Simplification. Endo is not simple. We know that. We both know that, and all of your townies know it, okay? But you can simplify something a little bit. And I actually retired from the university a little over 7 years ago. And I thought, okay, I'm going to be retired. I'm going to improve my golf game. It didn't improve, okay? And I love dentistry and I love endodontics so much that I wanted to keep my finger in it. One of my last positions at the university was as the assistant dean, and one of the things I did as assistant dean was to interact with the dental industry. And so I had some connections. And I said to myself, most of the endodontics that's being done today is being done by the general practitioner. They're always getting the short end of the stick when it comes to pricing, because it's the large companies, the large practices that actually get the best prices. That's why you'll rarely, if ever, see from the major companies the price online. What you'll see is check with us for the pricing, okay? Because every office, every practice has a different pricing structure. So what I decided to do was to look for a company.
And you're talking about rotary files mostly.
I'm talking about rotary files primarily, okay? But also other things. But I want to keep it simple. In other words, not a range of different products. What I found was the best product in a specific field. For example, MTA. One specific MTA that's actually packaged in capsules, because the average general dentist is not going to go through a bottle of MTA. What they're going to do is they're going to spill half the bottle before they get to the other half. So the economy of scale doesn't work for them. Plus, it's been shown that if you open a bottle of MTA, being hydrophilic, the last particles in there don't work the same because they've already absorbed moisture from the air. Even if you keep it sealed right after each opening. Once it's opened, it's not the same as when it was manufactured. So I was looking for some specific products that would simplify the user experience for the dentist, primarily the general practitioner, and also simplify their buying experience. I mean, look at Amazon and how they've gone from selling a few books to controlling the world. Okay, what's happening is that I said, let's use the power of the internet to bring to the average general practitioner or endodontist who want to become involved the purchasing power of being able to buy online. So I approached a company, Micromiga, in France, and Micromiga is probably one of the oldest, if not the oldest, manufacturer of endodontic files. They started in 1907.
Are they still independent, or did they get bought by someone?
Independent.
They're still, and where are they at? Italy?
France. They're in France.
France, okay. So Angelo Sargenti was in Italy, right?
He was in Italy,
okay,
right.
But this is France, Micromiga.
Micromiga. The Gyromatic we talked about, that was Micromiga.
Wow.
Okay. So Micromiga is a world player. Okay. They're up there with, as far as endodontics, with the Tulsa and with the, the Cybrons and everything. So they're a world player. So I went to them and I said, look, what I'd like to do is I'd like to private label your instruments. Not all of them, because dentists don't need 1,000 different file designs in their drawers. They'll find something they like, and that's what they'll use, but they don't need to buy everything under the sun or as soon as it comes out. So I want to try all of your instruments, and I want to pick the best one, 2 different systems, one a single file system, one a 3-file system, and I want to private label it. I'll private label it, and I want to simplify the package, and I want to also go ahead and take away the one thing that drives up the cost a bit, which is the pre-sterilization, because every dentist has a sterilizer. You don't have to buy something that's been pre-sterilized that's going to add to the cost of it, and just sell it online. Online only, which means no salespeople to support, no head office to support, no auxiliary offices to support, no branch office to support. Just sell it online, and the prices will be right there. Everybody will see what the price is. There's no volume discount because everybody gets the volume discount. And this is what we created. They agreed to, but we couldn't use the Micromiga name. We could only create our own name. So the name was Zendo to simplify things. It didn't hurt that the last 3 letters of my name are the same, Z-E-N, as Zendo, but that was a side issue. Okay.
So it's Zendo-online.com, right?
The company is Zendo. Okay. The online site is Zendo-online.com. Our prices.
But what did you say the site was? The site was Zendo. The site is Zendo-online.com.
Right. But the company name, the official company name is Zendo.
Okay. And how is that different than the Endoacademy.com?
So the Endo Academy. So listen, you can take the teacher out of the dental school, but you can't take the teaching out of the teacher. So I wanted at the same time to create a site where people could still learn a lot about endodontics without being forced to read ads. Okay, and so I set up this endoacademy.com. So it's called theendoacademy.com. It has one little block on each page that says that with Zendo, because I got to pay for it somehow, so the sales in Zendo help pay for this educational site. But you're not forced to buy to go on the site. There's no registration. There's nothing required to go on the site. So it separates the educational component from the retail aspect of it. Because I didn't want people to say, well, I'm a Tulsa user, but I really like to look at your stuff, but I don't want to be influenced. Oh, fine, don't be influenced, okay? But just learn about endodontics.
On the endoacademy.com, do you have online CE courses?
No, that's your job.
Okay.
That's your.
When will we get honored and graced with an online CE course from you?
Well, I don't know. It's coming up. I just started a blog on Dental Town, and I actually posted earlier this morning. I posted something that we had on the Endo Academy that was dealing with separated instruments and whether people have to be concerned if they've separated an instrument and the patient has to go for an MRI. Is the metal that's inside the tooth going to be a problem? So I posted the response from, I found an expert in that field who specializes in MRIs, and he gave a very distinct answer for this. Posted it on Dental Town because I know that's where everybody who wants to learn goes. So we posted it this morning, getting quite a number of readers.
We are out of time, but I have to hold you for overtime because you opened up a whole can of worms when you said that a single file system or a 3-file system. You have to go back and explain that. I know. My job is to guess questions, and our last episode had 7,000 viewers, so I know people were driving their car thinking, what's the difference between a single file system and a 3-file system? That's what you said, correct?
Yes, yeah, it's what I said. When various manufacturers talk about single file systems, us included, it's a file that will do all of the shaping of the canal. Now that doesn't mean it's the only file that you have to put inside the canal. What it means is that once you have access, and once you've got your orifice open, and once you have your canal gone from the coronal down to the apex so that you've established a glide path and your working length, then all you need is one file to shape the entire canal. Everybody touts, every manufacturer has a single file system, okay? Ours is called the Zone. And for those people who want to cut down the number of instruments they're actually using, the Zone is great because it has 3 different zones in the file configuration so that it can do the work of 3 different files. But there are those who are more comfortable in doing it step by step. And for those, we do actually have those 3 zones configured into individual files. So we have them in 3 files. But it still means you have to go open the apex. You have to get your glide path. You have to get your working length. You have to then shape the canal. So you can shape it with one instrument. You can shape it with multiple instruments.
So the single file system is called the Zone.
Right.
And what's the 3-file system called?
The 3-file is called the Zenith.
The Zenith. You just love the letter Z, don't you?
I love it because it's the end.
Yeah. And what is the I know you can't give a volume price or what, but on the whole for a general dentist, what is the difference in pricing buying going to Zendo-online.com and buying my files versus what they're paying through Patterson, Shine, Benco?
Okay, so for example, our files are all $29.95 a package of 5 files. Okay. If you were to buy exactly the same file on one of the other companies, okay, the prices would range. For example, the Zone is $29.95 a pack of 5. If you went onto another site, I don't want to name the people only because it'd be embarrassing for them, but it's over $90 a package.
Oh my God! So you're 1/3 the price.
Okay. Now, if you go to the Zenith, okay, we're $29.95 a package. Okay. The same site sells the Zenith under the Micromiga name as they're at $40 a package. Okay. So the price differential varies depending on the circumstance, but we're always much less for the same product.
So what percent less are you on the range? I mean, are you what percent would you say usually on the range?
I would say from 20 to 40%.
Okay, 20 to 40%. And then, sorry to hold you over time. I'm so grateful that you're here.
I'm grateful for the time.
But you're making my mind spin again. I always single use a file and throw it away. I mean, I can't think of a bigger nightmare than having a file breaking, and I almost never, ever, ever have one break. What do you say to the people who autoclave their files and reuse them?
I say, sleep better at night and throw them away because Howard does.
And would it be gross if you went in and got a procedure done on your prostate or heart or catheter and you found out they used it on the guy in the room next door before you and autoclaved it? Wouldn't that just be creepy?
It's worse than that. One of the problems is that if they autoclaved it and it was still okay, maybe, and if I didn't know about it, even better. But we put these files under stress, okay? And it's not the same as doing an upper cuspid and then going ahead and using a mesial-buccal canal and an upper molar, okay, where it's tight to start with. You're stressing these files out. It's just not worth it, especially at the price point now. It's just not worth it. And everyone should know, again, I don't want to point fingers, but every single company that manufactures these files, in the small print, say don't reuse. Single use only. They tell you that. And if you think they're going to back you up if you have a court case because you separated an instrument. And it's interesting, how we've developed a nomenclature. Files never break, okay? Because that means somebody has to break them. They separate because they just fall apart, right? So we always take the blame, shift it to someone else. But the manufacturers always say single use only. Doesn't matter what the salespeople tell you. How about, it's all right, you can do it 2 or 3 times. Trust me, okay? Always follow the manufacturer's rules of use when you're following the steps and when you're following the instructions, because it'll never get you into trouble.
Okay, we're at hour 5, so I have to stop. All I want to close with is that guy that followed you at University of Toronto.
Yeah.
My God, I'd love to do a podcast with him after you, the 1-2 punch. I would love that. If you can deliver any other legends like yourself to podcasts, please send them my way, because when I talk to the man on the street, the woman dentist in the practice, most of her stress in clinical dentistry comes from molar endo. I mean, it's not from a single crown. It's not from a filling.
Have hair.
and then my last thing I want to say is my mother, her big dream was to visit Jerusalem, and I sent her on some retired ladies trip. A whole bunch of ladies went over there, and I mean, my God, I think that was the highlight of her entire life. So, so thanks for Jerusalem, and thanks for all the tourism. And in fact, after I talked to you, I realized I need to hang up and call my mom and send her back again.
Well, send her to me.
Send her to you?
I'll take care of her.
All right. Well, she loved that. But anyway, okay. So anyway, thank you so much for your time.
Thanks, Howard.
All right. Bye-bye.